This episode of the GeriPal podcast is sponsored by Geriatrics at the San Francisco VA. They are looking for a CLC medical director, nursing home director, and also a director of their consult service. Pretty amazing job, right, Alex?
Amazing jobs. You get to work with people like us.
You get to work with
terrific people you've probably heard as guests on this podcast. And who knows, could be you being a guest in the future.
If you want to know more about this, you can actually email me, eric.wadera@ucsf.edu, or check out the show notes. We'll have links to the job position on the show notes. And if you're also interested in advertising your own job openings, feel free also to email me. I can tell you a little bit about that's how we support these shows is through donations and some of these job requests. So on to the show. Welcome to the GeriPal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, today we're doing GeriDerm, geriatric dermatology. Who do we have with us today?
We're just delighted to welcome Eleni Linos, who is a dermatologist and researcher at Stanford. She's Associate Dean of Research at the Stanford School of Medicine and also leads the Center for Digital Health. Welcome to the GeriPal podcast, long overdue.
Thank you so much for having me. It's so nice to be with you both.
And we're delighted to welcome Daniel Butler, who's a dermatologist and researcher at the University of Arizona, Tucson. And he's married to a geriatrician.
Hey!
Daniel, welcome to GeriPal.
Thanks for having me, guys.
So we got a lot to cover on geriatric dermatology, including, I got this mole right here that I just want you to...
Yeah.
It's probably like, you're probably sick of that joke, right? So we have a lot to cover, but Daniel, I think you have a song request for Alex. Is that right?
I do.
What's the song?
I've Got You Under My Skin by Frank Sinatra.
Do I dare ask, why did you choose this song?
Tough to say. It just came to me. One day in a dream.
Okay.
All right, here's a little bit. I've got you under my skin. I've got you deep in the heart of me. So deep in my heart, you're nearly a part of me. I've got you under my skin.
That was great.
I love singing Frank Sinatra. Thank you, Daniel. That was a great one. Thanks.
All right. Before we dive into the big topics of geriatric dermatology, I just love to hear from both of you briefly how you got interested in this as a topic. Daniel, I'm going to start off with you. Is it because you married a geriatrician, or is this pre-existing?
This was a pre-existing condition. I thought I was going to be a geriatrician. I had a little bit of a circuitous route in medical school. I kind of liked everything, and I was actually in Geriatrics clinic with Mindy Fain, who's a famous geriatrician. And, I was there and I was really interested in focusing care on older adults. And everybody there was concerned about their skin. They would have these, more mortal conditions like heart disease or cognitive impairment. And then they would ask about the itching or the spot on their skin. And so as a student, I started to get interested in who was looking at that, and there weren't many people. So I said, "Hey, that's a big grassy field to run in." And the other one that makes me interested in it, and I have to mention now, is I had 4 of the greatest grandparents that anybody could ever want, and I just lost my last one about 3 weeks ago. But they really showed me that aging is something to be honored and is a sort of a really unique practice. And I know dermatology has a complex relationship with aging because we talk a lot about anti-aging, but I felt like it would be really fun to talk about that honoring of aging and being part of that journey.
Ah, that's wonderful. And the U of A folks, University of Arizona geriatricians are just so marvelous. Just a big shout out to them. Yeah. Elena, how about for you?
For me, it was probably a combination of what Daniel says of having role models who are older. I grew up in Greece where, again, older people are really valued and respected. And then also going through residency as a dermatologist and realizing that a huge proportion of our patients are older, but yet we didn't seem to have any tailored approaches or even thinking of even a subspecialty. The words geriatric dermatology weren't heard a lot together, but pediatric dermatology is a subspecialty with a fellowship. And so I was really lucky to come to UCSF and meet Meg Kren, who's also married to a geriatrician who you know
There's
well.
a theme right there. Yeah.
So when dermatology and geriatrics collide, I think it just inspired a lot of much needed work at this intersection. And so, yeah, that's how my journey to geriatric dermatology started.
So I can imagine with peds, like it's you know, you treat things differently potentially, and there's different diseases. In GeriDerm, is it that different how you think we should treat some of these more common major issues?
I think so for sure. I mean, there's so many different issues, and there's a parallel to pediatric dermatology. So the role of the parent in some cases is equivalent to the role of the caregiver, or polypharmacy is a unique issue for older adults. Mobility issues and transportation, the social issues and who you interact with. I mean, there's several unique
Yeah.
issues for older adults that affect how we treat their skin. In addition to the biological issues, like older skin is just more fragile, more frail. Healing is slower. So yeah, I would argue for sure it deserves its own attention as a subfield.
Yeah. Oh, go ahead,
I'll
Daniel.
just add really quickly to that, Eric. The hesitation in our field, though, of really adopting this has been that dermatology, and I think this is probably true for a lot of specialties, is really disease focused. The infrastructure of research and program development is really like melanoma clinics, lupus clinics, psoriasis clinics. And even for pediatric dermatology, they didn't really take off until they had their own diseases, which were things like hemangiomas, which were birth defects of the skin, and atopic dermatitis. And the problem with geriatric dermatology, and it's not a real problem, but something that's perceived, is that it's everywhere. It's every general dermatology practice. And so without these exclusive diseases, it's been a little bit of a harder adaptation, but nevertheless still really important for all those reasons that Eleni brought up.
Mm-hmm.
I'm going to start off with, actually, I'm going to take a big step back. As we think about like the aging skin, I think probably all of our listeners want to know, what things should we be doing now to help with the fragility that comes with kind of aging skin, if that's true?
I'll take a shot at that one because I get it, about 100 times a week.
Yeah, you live in Tucson, so I can imagine there's this big glowing ball that most dermatologists like hide themselves from.
Exactly. Well, so that's the key answer: is just stay inside and never do anything, never touch the sun. No, I say that jokingly, and I want to be very clear. I think sometimes dermatologists, sort of lose the message. UV, or the sun, is certainly a cause of, morbidity, mortality, but really it is the cause of most of the aging of our skin that we see. So making sure that you're well protected from the sun. You should still be out in the sun, which is a very clear recommendation. You should be out running, you should be out playing, you should be doing things, particularly, in really nice places like San Francisco. Be out and about, but be vigilant when you're out. And then the other easy piece to that is just make sure that your skin is well moisturized and taken care of. We do a lot of things in this world that harm our skin barrier. The pollution outside, harsh soaps, really fragrant things. All of these in some sort of moderation are not going to cause overall damage. But the more we can think of our skin as sort of an active participant in our lives, so you want to make sure that it's hydrated, just like we go out and we take care of our muscles by exercising, or our hair by shampooing. You want to make sure that you're moisturizing as well. And those are sort of my skin longevity pearls. Obviously, there's plenty of other things. And if you're on, social media for 2 seconds, you're going to get bombarded with 1,000 other things to do that are going to lead to skin longevity.
Do I have to spend a lot of money on the hydration stuff, or can I just get the cheapest thing at Walgreens? And what would that be?
Yeah, my recommendation is not product specific. If you want a good hydrator, get it in a tub that you can scoop out and make sure it's not fragrant. Doesn't matter the product name. Those two are my easy recommendations. You don't need to spend a ton of money.
But can I ask, you told us we can argue with each other.
Yeah, go ahead.
I've known Daniel for a long time, and so I can say this, but now that we're not talking for older adults, but for the general public, there's also a do nothing until you need to do something approach. Like you don't
That's
not
my
everyone
approach.
needs to moisturize.
That's
Like,
my
I just
approach.
want to say that, like, unless there's a problem, you could also just live your life and not do anything
Yeah.
to your skin and, just shower and shampoo your hair. Like, you don't have to use a moisturizer every day and you don't have to use sunscreen to sun protect. So I just want to make that clarification. You can protect yourself from sunburn by simply not going outside on midday and like doing your runs in the morning or the
Yeah.
evening or wearing a hat or wearing sunglasses. So I think there is a big industry that promotes spending a lot of money and buying products, but I just yeah. Daniel and I are friends, but that's not doesn't you don't have to do any of that.
I think that's a great recommendation. And I think that's really important for people to hear too. Mine is coming from when someone asks, when
Yeah.
someone asks us in clinic, they're like, hey, what should I be buying? And like, that's sort of a
Yeah.
low hanging fruit. But Eleni's totally right. And, I think sometimes simplicity is absolutely the way to go. Your risk for sun exposure related things and xerotic changes or dry skin changes, those are very different for very different people. So I totally agree with Eleni there.
Now, while we're on the subject, this is great. We're getting so many questions. Okay, I've got some friends who I hike with, and they're like, hippie Berkeley types. They're like friends from med school, and they were like shocked that I was using this, sunblock that wasn't like a barrier protected sunblock. It was one of those old types of sunblocks,
Oh,
whatever those are. Do you know what I'm talking about?
Yeah.
Like, should we really be concerned? I don't know what the name is for the old type of sunblocks as opposed to the zinc or whatever the barrier types of sunblock. Is that a real deal or is that overblown?
Yeah, Daniel and I may disagree on this too, but there's nothing wrong with using sunblock or sunscreen at times when you need to use it, right? So I use it on my kids and on myself when I'm about to go swimming, if you're on vacation and you're out in the sun a lot, if you're going to be out midday sun. So that there is a time and a place to use it for areas you can't cover, and it does prevent sunburn. It does work. But at the same time, there's so many other ways to protect yourself from sunburn, including, the ways I just mentioned, like hat, long sleeves,
Long sleeves.
that I think
Yeah.
sometimes we fall into this pattern of just assuming that the only way of sun protecting is this chemical sunscreen.
Yeah.
But in terms of the ingredients, you're right, Alex. There's a huge, huge concern with some of them, both for ocean,
Yeah.
planetary health reasons, but also for endocrine metabolisms reasons. We're actually doing a study right now where we're measuring microplastics in these sunscreens as well. And so it's super interesting. But for me, I would say as long as you are sun protecting in moderation, and using all these other methods, areas, you don't actually need to use that much of any
Yeah.
particular.
When we're in
Daniel,
the
what do you think?
Sierras and we're hiking, we hit these through hikers and they don't use any of it. They just cover up because they're like, I would have to put, I'd have to bring like 3 gallons with me in order to
There was a
do the
meme going
recommended
around
amount.
about a dermatology conference in Hawaii, and you just saw
Yeah,
all the
that's the one.
dermatologists on the ocean just fully covered in clothes.
That's how we roll.
Daniel, your thoughts?
Yeah, I mean, I think Eleni hits on a lot of good points there. I think, the debate of the chemical sunscreens versus the physical blocking sunscreens, Alex, which is the sort of balance that you're using, it's hard, and it kind of is a microcosm of a lot of the places we are in medicine where, sort of pop culture and minor risk factors, get potentially blown out of proportion of like, hey, if you use a chemical sunscreen, all of a sudden, you're doing something wrong. I think the balancing act is exactly what Eleni said, which is like, you find the way to protect sun that works the best for you. There's some people who barely need to do it whatsoever. And there's some people who are out in the sun for 2 seconds and they're going to burn. And so the needs for those people are going to be different. But back to your exact question is, we do typically recommend the zinc and titanium, which are the physical blockers, because they are more effective and they're less likely to get into your system. And there were some studies that the chemical blockers can get into your bloodstream. And there was a study, I want to say about 10 years ago, where it was at higher levels than was expected by the FDA. But from an outcomes research standpoint, there hasn't been a connection between the chemical sunscreens and any negative outcomes. So So there's a lot to fill in the middle there. So that's some of the debate. And I think it's, it's interesting, but I will tell you what I do is I use physical blockers when I need to, and I burn it like in 2 seconds, but they can be a little bit, cakey and white on the skin. So you don't love those. So if I need to, I'll use a chemical sunscreen on my face when I'm going to be out and about, but I can't look like a ghost, which I already kind of do. So it's delicate balance.
Yeah.
Okay, as Alex was walking up that Sierra and he saw the people without anything on, he noticed someone had an actinic keratosis on his skin. And they asked Alex, what should I do about this? And this goes to the next section.
Wait, can I give a real world?
Yeah.
My mom yesterday, she's in her early 80s, and she says, I have these things on my skin. And my dermatologist says, don't worry about them. They're growing slowly. They're nothing to worry about. And she said, maybe it's a keratosis or something. And I said, okay. And then my mom says, but I want them out. I want them cut off and I want them sent to the lab pathology because I'm worried it's cancer. I don't know. Should she be worried? What?
Yeah, and I was actually prepping for this podcast. I was looking at some older geriatrics books, and they give me these wide intervals of how often these AKs turn into something that we're actually worried about. And then I look at newer stuff and it's kind of all over the place. How worried are both of you around AKs, and how should we deal with actinic keratosis?
Should I start, Daniel? Or
Yeah, go for it.
So first of all, Alex, I think your mom may have seborrheic keratoses because if the dermatologist told her not to worry, they slow grow, and it might be a keratosis. In my mind, I think that's probably what, without seeing anything, she might have. And in that case, truly, she doesn't need to worry. But I would say if she wants them removed, that's totally okay, and we can very easily do that. And I'm sure you can too. We can freeze them and they fall off. But in terms of actinic keratoses, it's a really interesting question. Sorry,
Eleni, can I ask you? Remind me what the difference between the two are.
Seborrheic versus actinic keratosis.
Yeah. I wonder if I have time to screen share and show you pictures. Basically, one is, the brown, round or oval kind of bumpy surface. They're and bumpy, and basically everyone has them after a certain age, and they're on your back, usually on the back, or they can be on the face.
Yeah.
The actinic keratosis is pink and scaly with kind of more of a white and usually smaller. They might only be, 2 to 3 millimeters, while the SKs are larger. Daniel, how would you rate my description?
Perfect. The brown velvety stuck on looking ones versus the rough, more, poorly circumscribed red ones. That's the difference. I thought you hit it right on the head.
That's seborrheic versus actinic.
Correct.
Yeah. Okay.
Right.
Seborrheic ones are harmless. The actinic ones have a very, very, very low risk of progressing to a squamous cell carcinoma, and that's why we pay attention to them.
Mm-hmm. And is that risk over time?
Yeah, the latest statistic I remember, Daniel, I don't know if you have more, is 2% will progress over the course of several years. Is that Marty Weinstock's latest data, or?
Yeah, I think his was 2, and I think that was one of the more, from a single lesion that was the risk. And, most of the time, if you have one, you're going to have a handful around them. So that risk is, someone you're trying to sort of value that risk can be challenging, but around, I think anywhere between 0.1 to 2%, which is, I think, Eric, you hit it on the head. It's kind of all over the place, that risk.
Do you remove all of them, or do you think about prognosis and do you send them to pathology?
Definitely don't biopsy those. So that's a really good distinction to make. So we do not remove those. Don't biopsy those. I mean, traditionally, sometimes you'll have some really big ones that you do biopsy. But those are the ones that you're typically getting frozen. So when somebody, hopefully, Alex, when your mom left, she didn't leave with a bunch of what look like pock marks after. But that's a typical experience for a older adult coming into the dermatologist, and typically that means that they had a series of actinic keratoses frozen. And then the other treatment that's a gold standard treatment is 5-fluorouracil or Fudex, which you typically put on the skin for a couple weeks. Those are things that we definitely do use, but certainly there's nuance for all people, but particularly in older adults, which happy to get into further.
Okay. Well, is it okay if do you have any other questions on AKs? So I learned also something in my research. The most common cancer in the US, do you know what that is, Alex?
Basal cell.
Basal cell. If you add up all the other cancers that US adults get, it still isn't as much as the basal cell carcinomas out there. So not only the most common skin cancer, the most common cancer, do you treat basal cell any differently in younger adults and older adults?
It's a great question. My favorite question. Because this is what the question that got me into geriatric dermatology, and it started with I still remember this patient so clearly. I was at the VA in Palo Alto as a resident, and I was learning dermatology, and it was a frail elderly veteran who was being wheeled in by his daughter, and he had a basal cell on his ear right here on the helix. And I was so proud that I diagnosed it and I biopsied it. And then we used to look at the slides in pathology under the microscope. And I called the patient and I brought him in for Mohs surgery to remove it. And then he had a 3-month follow-up. And then I found another one nearby and biopsied that, same process. And this happened, he was in and out probably every couple of months between the follow-ups and the Mohs. And when I called him to give him the update on the third time I biopsied him, I called and he had passed away of unrelated causes. And that was the moment where I was like, what on earth did I do to this family for the last 6 months? There was no reason based on the speed of growth of basal cells for me as a very eager, attentive doctor to slowly cut pieces of his ears off and have him in and out and bring. So
what is the speed of growth? Are you worried about metastasis? Are you worried about local invasion? What are you worried about?
So typically the vast majority of these grow very, very slowly over years. They don't metastasize. And the vast majority of them, like low risk prostate cancer are lesions that people don't die of, but may die with. And so the key for us as dermatologists is to balance the risk of that tumor growing and causing symptoms locally if it ulcerates or bleeds versus the patient's life expectancy and all the other health conditions they may need to prioritize. So this became an area of research focus, and that's where I was so lucky to meet many of the amazing geriatric researchers with you at UCSF.
And just a shout out, we'll include a paper that you did on active surveillance. Was it, I think, JAMA Internal Medicine? I forget. That was a while ago now. That was pre-COVID, I think.
Pre-COVID, yeah. It was very controversial among the dermatology surgeons. Dan may remember.
Oh.
Is it still controversial?
Yeah. Can you say why? Yeah.
So I think at the time, when, with several colleagues, we published this idea that maybe we're over-treating, maybe we're doing too many procedures. Let's take a step back and think about what is appropriate and how do we balance the needs of an older adult with this slow rate of growth of these tumors and the potential side effects of surgery. I think that was the main, the main concern. I think the geriatrics community was very understanding because obviously you have many other examples of watchful waiting, of balancing procedures to the patient's preferences and life expectancy. But the dermatology community wasn't as ready, I'll say. And people weren't happy with me. But I don't think it's controversial anymore. I feel so lucky that now it's in our textbooks, it's in our guidelines. So I'm very impressed with our field's acceptance of some of this research.
You feeling the same way, Daniel?
100%. And I mean, I think we're all lucky, and I was lucky to have Eleni as a mentor, but, we're lucky to have really the world expert, Eleni, on both, basal cell natural history. I remember the trial you did or the study you did when you were in Greece, looking at the timing of a basal cell, which really no one had ever looked at. And then, introducing this concept to, a world where we have every single influence that's on us as physicians is to biopsy those lesions and do more, right? It's a systems issue. It's not a someone, some greedy dermatologist, or at least this is my take on it, is, a greedy dermatologist is wanting to do more. A lot of the times the patient is like, cancer, get it off me. And then, really what it takes, and what Eleni's work has led us to, is we can then take that sentiment and be able to unpack it and say, well, hey, there's actually options here. And if we're seeing you regularly, this probably has almost no risk of becoming more than it is right now. But it's still controversial from time to time. And anytime I mention that I do geriatric dermatology to a Mohs surgeon, they're like, well, do you think that I'm like trying to hurt people or what? So it's as every good research does, like it provokes people. And I think ultimately at the end of the day, we've leveled off a little bit.
Yeah. Eleni, could you say a little more about, I remember talking to you when you were either in Greece or headed to Greece about your work on an island. Is that one of the blue zones? And you saw very old people, and some of them had sort of untreated basal, watchful waiting sort of approach. Is that?
Yeah, that was it was a really fun study. And it came about because I remember being at UCSF in Meg Kren, my mentor's office, and we were looking at this New York Times article with beautiful photographs, portraits of these, 90, 100-year-old people living on the island of Ikaria, which is one of the blue zones. And as dermatologists, we were studying them carefully and thinking like, oh, I see something there. I see, because we could spot the AKs or, potential SCCs or BCCs, even from these photos. And that's when we realized that maybe there are populations that are not, because in the US, as soon as someone has even an AK, it's frozen, right? There isn't
Yeah.
a population that is living with these potential skin cancers. And we thought a rural island without a doctor on site probably, and from, we had suspicion from these photos, probably may have several people, especially if it has a significant older population and sun exposure, has a significant number of people living with untreated AKs, untreated basal cells. And so we designed the study to go investigate that there. But since actually there's been a much better study than ours in the Netherlands that looked at watchful waiting for basal cell, and that followed patients longitudinally and showed very similar results. So I'm really happy it's been repeated.
Mm-hmm.
Great. I wonder if it's okay if we move on to another topic. Anything else you guys want to say on AKs or basal cell?
I'll just reflect on Eleni's story about that chagrin of, having felt like, what was I doing cutting off this patient's ear? And they weren't going to die of this cancer anyway. And then they ended up dying. And that we can learn from those clinical experiences. And in some cases, it like launches a career. And so if people are listening and they're like, what was I doing there? What was I thinking? Or what were these other people thinking? That's like a really important question. And sometimes that's the beginning of an insight that's like fresh and new for the field. And so I just want to thank you for sharing that story.
Yeah. And I might add to that, Alex, that for all the younger people listening, your ideas that you may not be sure if they're good ones or nobody else is thinking it, those are the best ideas for the field, because you by definition are seeing a whole area of medicine with fresh eyes. For those of us who are older and have been here, we don't have that. We can't, we're already in it. We can't see through to it. So your clarity is a superpower. So trust your instincts. If you think something is not right, you're probably right. And if you have an idea that seems crazy, follow it for a little bit at least.
I love that. And I remember, Eleni, you saying something similar to me, over 10 years ago. So it's great advice. The only other thing that I want to add to this is something that sort of captures this together, which is there's a famous quote from Jurassic Park, believe it or not, very famous text, Jurassic Park. Jeff Goldblum's character asks the question, he says, or it says, your scientists were so preoccupied with whether or not they could do something that they never asked if they should. And I think oftentimes that's the plight that we're talking about here, which is like you have these hyper-specialized people, these dermatologists who are trained to see the smallest basal cells, and that's sort of like what they're supposed to do. And these Mohs surgeons who can do incredible procedures and reconstructions, but someone has to be having the conversation of like, hey, I need to actually see if this is something we should be doing and if this amazing skill set is really indicated here.
I love that. And I think that's the first time, Eric, in over 400 podcasts, we've had Michael Crichton and Jurassic Park quoted.
Life will find a
That's
way.
terrific.
There you
Well
go.
played,
The
Daniel.
other
Well
one.
played.
Well, whose job is it? How should we work with a dermatologist then?
I love this question because it's different everywhere. And I always use the analogy, and we've sort of talked about it. Eleni, you pointed to it. There's something called the conveyor belt in medicine, which is like you have a diagnosis, and once that diagnosis is there, you get on the conveyor belt. And someone has to have a stop at that conveyor belt. So sometimes the general dermatologist is needing to have that conversation. Sometimes it's the Mohs surgeon who needs to be having that conversation. But it's basically asking the patient, hey, here is a low risk lesion. And there's a lot of context to this, but let's say it's just a standard basal cell. It's a low risk lesion. It's very unlikely to cause problems for the next 5, even 10 years. If we follow up, relatively closely, 3 to 6 months, and we watch it, you are safe in doing that, but it may require a bigger surgery if we need to do a surgery later. How do you feel about that? And then here are the risks of the surgery. So somebody has to be able to stop the conveyor belt. And I don't think as dermatologists or any specialists, they should be putting that on the geriatrician or the primary care to be doing. And that's partially my wife speaking through me, but I really firmly believe in that. If you do the procedure, biopsy or excision, you should really be the one who's stopping the conveyor belt and having that conversation. And I will say, sometimes you talk to people and they say, I want, 100-year-old, want that gone. And really, Mohs surgery is a very geriatric friendly surgery. It's very well supported. It's outpatient. So there's a lot of pluses to it. And you listen to the patient there, you say, that's fine. And the conveyor belt continues.
But it does sound like the concept of lag time to benefit. How long does it take to see a benefit? You're looking at least 5 to 10 years for these more innocuous basal cell carcinomas.
I will say it depends on the location too. So if anything is near the eye or, somehow impeding function, obviously, I would be more likely to recommend treatment or excision.
Mhm.
But sometimes they're in the middle of someone's back and they don't even know they're there. So, and they're tiny and not ulcerated. So we do have guidelines on, and I think they're based on like size for watchful waiting. So small size, I think it's either less than half a centimeter or less than a centimeter on the back, not ulcerated, in someone who has a short life expectancy, then the recommendation should be to follow up clinically or watchful waiting.
Okay. All right, I got a question. One of the most common symptoms that we see in older adults and in the palliative care population too is itching, or that generalized itch. Any quick thoughts or how we should be thinking about the itching in older adults or itching in palliative care populations?
This is, Eleni's favorite is the basal cell discussion. This is my favorite discussion. Itch is my favorite thing. And the reason why I love it is part of the answer to this, which is, we for a really long time have minimized the symptom of itch, despite the fact that it's the most common chief concern that people go to a dermatologist for over the age of 50. And for a really long time, itch and allergy were sort of intermixed. So if you were itchy, then you were allergic. And like that was the answer as to what was going on. But what made me so interested in it is now we really understand the pathophysiology of itch, and it's really complex but fun. And in all these systems that we have that are aging in our skin, things like the barrier of our skin, the immune system in our skin, the nerves in our skin, they all as they age, they all contribute to that itching phenotype. And so targeting each one of those different systems is what we're now doing to treat these itchy patients. So I know I got nerdy and scientific there, but there's something there because when people ask me, hey, Dr. B, I'm itching, what's going on? I say, it's not that you're eating the wrong thing. It's not that you're allergic to anything. It's one of these 3 systems, the immune system, the nervous system, or the barrier of your skin that are aberrant, that are behaving incorrectly. And we need to figure out how to recalibrate and rebalance. So that's how we do it. And each one of those has a different target. So the barrier, moisturizing. So many older adults are xerotic or dry. We start with the barrier. And sometimes that's enough. Sometimes it's not. If it gets them 50% better, great. Then we look to the nerves or the immune system. So the immune system would be something like, if you're seeing eczema on the skin, we could treat that. And then there's also these cutaneous nerve dysesthesias or itch syndromes like notalgia paresthetica, which is when someone itches right on their mid back. So there's a lot of variance between these, but that's really
Like very specific mid back itch location. How does that? Why in the mid back? Like what's
cervical spine. The ongoing theory is there's some sort of entrapment of the nerves from the cervical spine. As they leave the cervical spine, they can get entrapped in the foramen, they can get entrapped in the trapezius, they can even get trapped in the brachial plexus. So these are all places that can contribute right back to itch there. The other place that you'll often see it is on the dorsal forearm, which is called brachioradial pruritus.
And the one in the back is notalgia paresthetica?
Yep.
Now I have a name for the reason my wife asked me to scratch her back.
Yeah. Besides a back scratcher, what else do you do about that?
I don't mean to monopolize the discussion. So
No, go for it. Go for it, Daniel.
Usually if it really is that central mid back itch, then we'll use something that's nerve related. So something like a Sarna lotion, something that has a coolant effect, or even an ice pack. Those are more targeted than, say, I'll use the bad word in a geriatric podcast.
Don't say gabapentin. Don't say gabapentin. Oh, okay.
What did he say?
Or gabapentin. You want to go for something that you're actually targeting in there. Now, we do use gabapentin for really severe cases.
Yeah.
This type of itch, but certainly never where I'll start. I'll try to do even interventions. I'll send them over to pain management for a spinal injection if they need it, rather than get them on high dose gabapentin. But from a starting standpoint for this podcast, something like an itch cream, you can go find a CeraVe itch cream, which usually has some pramoxine in it, which is a cooling agent. Or again, ice packs and cool showers. Those actually hit the itch receptor and cool it off.
So when we did a podcast about palliative care in kidney disease, they talked about the itch, which is so common in advanced kidney disease, particularly if you're treating it conservatively without dialysis. I think they said gabapentin.
They did say gabapentin.
They said gabapentin because they said it's neurologically mediated, which I think falls in line with What do you think when you hear that?
Yeah. Well, I will say that's another, we're sort of reimagining itch everywhere. There's actually evidence of this nephrotoxic itch that we see, that it responds to gabapentin. It also responds to immune suppression. So we don't really know which of the two it is. And it's probably a mix. Some people are more immune related, some are more nerve related, but it's certainly not just a pure algorithm of like, if someone has that nephrogenic itch and they're not doing dialysis or something to clear, then they'll respond to gabapentin. Sometimes they need an immune targeted agent. So I'm only putting that in there to say that it's a total open world there that we're just starting to understand.
So I got the skin, I got the nerves, then you got your immune system. How do you target that? Let's say if they have more generalized itch.
Target the immune system?
Yeah.
I mean, I'll keep going here because this is my favorite.
Yeah, run with it.
Usually we start with, topical steroids are a great place to start, not just as a forever treatment, but as almost like a theranostics is the word I use, which is like therapeutic diagnostic. So I'll give an older adult a topical steroid and say, look, I'm not giving you this forever.
If there's a specific location for the itch?
No, that's usually when it's generalized. And I'm worried about an immune-related itch. So I'll give them a big tub of triamcinolone, which is a fairly low-cost, easy-to-use topical steroid, and have them use it for 3 weeks, even up to 3 months.
Like all over?
All over, yeah.
Wow.
And I'll say, hey, if you come back and this is working for you, then we'll have a discussion of if this is going to be something that can work with your life. Do you have someone who could put it on? What are your abilities when you can actually use it? For the record, if you've ever put a cream on all over your body or an ointment all over your body, it's generally a miserable experience and it ruins everything in your house. So we also have to talk about sort of the practical side of using that. But from a diagnostic standpoint, that can be really helpful in that initial step. And then we're really lucky to live in this advanced age where, 10 years ago, I would never have believed we would be there, but we now have these advanced therapies that are traditionally used for eczema and atopic dermatitis that are really clean medications. They don't have drug interactions, and they really work for this immune-related itch. And we call them, they're in a class called the biologics. They're used all over the place. You've seen commercials for them, but they're really wonderful. And I find that they work wonderfully for older adults, and they really fit the sort of geriatric mantra because it's, easy adherence or easier adherence. You get, one or two injections a month, and that really helps.
Can I have 2 lightning round questions? Because I do want to go to Eleni and just ask a question about digital health and AI.
Sure.
But before we do that, 2 questions around itch is, are there medications that you, as a dermatologist, will think high risk for itch?
Causing it.
Causing itch.
Yeah. And this is always the tough question. There is no single medication that like you give and it leads directly to itch. Interestingly enough, the best evidence for a medication that leads to itch is actually delayed about a year, and it's calcium channel blockers, particularly in older adults. The other one that can lead to it is ACE inhibitors, but I think sometimes they get a bad rap because you're seeing a lot of people on them, and then you're seeing a lot of people with itch, and so that connection has been made. The one that's the most growing right now, where itch is the number one cutaneous concern, is the immune checkpoint inhibitors. So particularly in the palliative care population, you may see that very regularly because that is so common in that group, and there's a lot of reasons for that.
What do you do about that one? Anything?
Well, that one's, I wouldn't say it's fairly easy, but at least diagnostically we know where it's coming from, because typically if they're on an immune checkpoint inhibitor, we know of the 3 buckets that they're very likely immune related. So we can kind of go up our immune ladder, which again starts with the topical immune control and then goes to the more aggressive systemic immune control.
My last lightning round question is, you haven't actually mentioned antihistamines. Do they play a role in any of those 3?
No, and that's intentional.
Taught us well.
Yeah, that's intentional. I'm well trained. The geriatrics community has made it, and this is part of like sort of what I see as our role in geriatric dermatology is uncoupling this concept of like itch, allergy, antihistamine. Because honestly, 50% of people who go in for itch to an urgent care or even a lot of dermatology clinics are going to get an antihistamine. And there's very, very limited evidence that it actually is effective and or targeted. So I do not use antihistamines for itch. There is, just to be comprehensive, there's a subpopulation that people are now starting to study where they see some mast cell overactivity that are part of the chronic itch group that can respond to some advanced antihistamine type therapies. But for the most part, we never use it.
Wonderful. You had a paper too, right, Daniel, on chronic itch in older adults, and was it JAMA Dermatology or was it JAMA IM? I forget which one.
It was JAMA. It was the big JAMA, I think.
The big JAMA. We'll have a link to that in our show notes too. So if you want to go walk through that, you can. Eleni, I'm going to turn to you for my last question. We'll see if Alex has more. Sometimes it's hard to get our patients to see a dermatologist.
Yeah, can we just take a picture of that and upload it to ChatGPT or Claude or Gemini?
How does AI fit into all of this?
Yeah, it's such an exciting time for AI in dermatology and AI in medicine in general. Okay, well, you already know that these models pass the board, step 1, have factual medical knowledge equivalent to physicians. Several studies have shown that they are just as good as dermatologists as diagnosing images of potentially malignant lesions. So they can, in terms of a single point of time, is this kind of cancer? Is this melanoma? These models are ready already to diagnose with the same accuracy. One really interesting study we did recently, about a year ago, was to look at the combination of AI plus human to see how these AI models assist or augment the abilities of a physician in diagnosing a skin cancer. And interestingly, they improve everyone's performance regardless of their level of training. So they will improve a medical student's diagnostic ability, a primary care doctor's diagnostic ability, and a dermatologist's diagnostic ability. So the combination of AI plus clinician kind of raises everyone's accuracy. What's really interesting as a next step is to figure out, and we're working on this now, what the most effective way to present that information to clinicians are, because ultimately it's about implementation. People are busy. They don't want to go to, another app or have to do anything that takes more time. And so it's really interesting to look at what are the most effective ways to to support clinicians so that these tools can be used in routine practice. But also, interestingly, the way the information is presented to clinicians may vary by the way they cognitively analyze data. So we did one study where for a group of dermatologists, we showed them other examples of AI generated malignant lesions or other similar, sort of like a Google Images search, versus for another portion of dermatologists, we just described the text. Like these are the reasons, the features that, seem malignant. And depending on whether you process things visually or you're better at analytic cognitive reasoning, the way the AI assistance is presented to you makes you, more or less effective. So there's a lot to do here.
Are there any current tools? Because I think if you go to ChatGPT or any of the big language models right now, if you upload a picture, it will say it won't tell you what
Oh,
it
really?
is. Yeah, I tried
You
that
tried
at least
it?
like a month ago. I tried
Oh.
it, and it would
I've
not be
done
my
it.
dermatologist.
Yeah. I have done it with, my son's x-rays for broken bones and stuff until
Yeah.
we're waiting for the report. I think there are a lot of tools right now. There's a lot of very effective tools.
Any ones that you trust that
Well,
we can?
I don't know if any of them yet have made it into the clinical
Okay.
flow. So I'll get back to you on that as soon as soon as some are ready.
Eleni's
But
in the heart of Silicon Valley. She's on the leading edge there. She's right.
well, yeah, but yet we still don't have something in our clinic that we use routinely. We do, one thing I will mention is we do really care about longitudinal follow-up. So for inflammatory diseases and even for basal cells that you're watchful waiting, that you don't want to remove, what you want is a tool that can assess change over time. So that's the next step.
Daniel, do you use any of these tools? Have you seen anybody use any of these AI tools?
They're incredible. And I think every dermatologist is, hoping that Eleni can usher in a collaborative world with AI. But I know a lot of us are like, uh-oh, my eyes are about to be secondary here. So I better get really good at sort of geriatric care principles so people want to come see me and can walk me through this. But, we don't use anything, but I think it's front and center now. And I think, the coin of the realm will change. I think visual diagnostics, which is a huge part of our job as dermatologists, will become a little less necessary. And, while it'll still be a major part, we're going to have to be people who are explaining treatment options and walking people through the variable chances that the algorithm shares with us. And this is just off the cuff, Eleni. You could probably explain this way better than I can, but that's kind of where I know a lot of us are in the clinical world.
Cass, one more question because I know time is up. Because telemedicine is playing a bigger part. Like, can you diagnose people via telemedicine?
Yeah, so I'll answer this very quickly. Yes.
Yeah.
And what's really important that we're studying now is how to make sure older adults are not left behind from any telemedicine innovation. So we're doing a study specifically on older adults and photo sharing to try and make sure that the quality of the images that patients send from home, especially if you want to collect them longitudinally, is adequate for clinical use and diagnosis. And so far we're finding, amazing results. Like older adults can send high quality images. It's very dependent on the body location.
Yeah.
So they may need different instructions and lighting depending on where it is.
When I've been to the dermatologist, they brought out, what is the thing that put in it looks like a loop?
Dermatoscope.
How do you deal with that? Like, you don't have one of those on an iPhone camera.
Zoom.
Yeah, a lot of people
Macro
are
lens
too.
Yeah.
I feel like if you have us back on in like a year, the world will have changed.
Okay.
There are companies out there that are doing full body dermoscopy, which is that, that overpriced microscope that you see for every lesion on the body and having AI analyze every single one of them.
Right.
Wow.
So that's imminent.
Well, I want to thank both of you for being on. We're going to have part 2 in, I guess, 1 year with both of you and our AI overlord. But maybe before we do, we'll have a little bit more of Under My Skin.
I've tried so hard not to give in. I said to myself, this affair never can go so well. But why should I try to resist when, darling, I know so well I've got you under my skin.
Lovely. Eleni, Daniel, thank you for being on the podcast.
Thank you so much.
You.
Thank you, guys.
And
Right.
to all of our supporters, thank you for your continued support. We'd also like to do a special shout out to all of those supporters who've donated more than $250, including
Brian Castle, Victoria Brond, Susan and John McFadden, Christopher Heck, Emise Samoji, Matt Schuster, Carrie Hagan, Lloyd Woolstat, Kari Levy, Marnie Fetzer, Ron Sabar, Stephanie Gabatuller, Patrick Lally, Richard Lewis, Margaret Young, Cindy Harris in honor of Emily Guillot, April Sear, Anna Naik, Xinyi Wang, Sudha Chandrasekhar, Michael Reisner, Asher Edwards, Susan Nelson, Rebecca Goldstein, Rochelle Bernacki, Carol Dietrich, Mark Andrews Wren, Elizabeth Cobbs, Amy Rack, Meg Walhagen, Xinyi Wang, Sharon Bragman, James Tulski, and Yana Scharf, Kelly Strait, Michael Bordowski, Jessica McFarlane, Gretchen Schwarzy and Joshua Mesrich, Rob Razak, Diane Meyer and Sean Morrison, Elizabeth Chung, John A. Hartford Foundation, and Harry Hahn.
thank you very much for your continued support over the last year. Your support keeps these lights on.